Good afternoon. How are you all today? I love the sea of red out here. This is pretty incredible. You know, I had the Gables East renovation meeting this morning, and I noticed all this red out there, and it didn't dawn on me until about halfway through the meeting that everybody was ready for the meeting for the lunch this afternoon. So, excellent job. I put a note on my calendar. Smita told me I had to wear red today, so I put a note on my calendar to make sure I got my red in. So, there you go. But well, welcome. I am here just to do a quick introduction of some of the folks you're going to hear from today. So first, just wanted to introduce Dr. Farhan Majeed. Dr. Majeed, so you guys are going to get to hear all about heart and cardiology and things like that, but he is with the Pulse Heart, Valve, and Vascular Institute. So very thankful for him coming here today. And I am going to introduce to you all Sharon Ivory, the Market Director for ShorePoint Health, and she's going to take over so you guys don't have to listen to me talk all day today. Thank you, Sharon.
Thank you so much, Brian. So as Brian mentioned, my name is Sharon Ivory, and I'm the Market Director for ShorePoint Health, Port Charlotte, and Punta Gorda Hospitals. First off, I just want to thank everyone for coming today. We are so excited to begin the community lecture series with Southport Square. Our goal at ShorePoint Health is to promote good health, prevention, and awareness. I would like to take a moment to thank Brian and Smita and the entire team for all of your hard work and your partnership and collaboration with ShorePoint Health. As we are aware, February is Heart Month, and it's a time for us to focus on our cardiovascular health. It's a month to raise awareness on the importance of a healthy heart. So with that being said, I have a few housekeeping items too. So,
get the microphone closer to you.
Can you hear me now? I know I'm a little soft-spoken. But I wanted to make sure that everyone has a ticket for our raffle. We're going to be raffling off a gift basket created by yours truly. And then we also have some Dunkin' Donuts gift certificates as well. So I want to make sure that everyone has a ticket. Well, you know, Dunkin' Donuts, they have healthy options as well. And then the other item is I look for everyone's feedback as far as future lecture topics. Because again, you know, it's about you meeting your needs and questions and to promote health and awareness. So please don't hesitate in reaching out to Smita or even myself so that we can begin our lecture series. I just want to say too that next month is colorectal month. That's March. So we do have a physician, Dr. Amadi, who's scheduled for a lecture March 29th here. So I look forward to seeing everyone next month as well. So without further ado, I would like to introduce our first physician lecturer, Dr. Farhan Majeed, interventional cardiologist, who is the founder of Pulse, the Heart, Valve, and Vascular Institute in Port Charlotte. Dr. Majeed's goal is to provide patients with the high quality, compassionate, and service-oriented care they deserve. So again, please join me in welcoming Dr. Farhan Majeed.
Can everyone hear me just if I speak like this?
No.
No? Oh, no. Oh, okay. Can you hear me now?
Yeah.
Okay, all right, okay. So, I hate microphones, but still. So I actually want to start off with an anecdote, why it's very cool to be me, okay? So, again, I moved to Florida about 4 years ago, and my family actually grew up here, and was my father was a neurologist, and my mother was a gynecologist here. And so I was up in Baltimore, and as you know, Baltimore has a lot of snow. Okay, so Florida doesn't have snow, and that's probably why you guys are all here. So my wife and I and my kids were in Baltimore, and I was covering the heart attack call that day, that weekend. And so so it was supposed to be a very, very big snowstorm. It was supposed to be like a few feet of snow. So my wife said, and the hospital was saying, "Oh, you need to stay in the hospital because you're not going to be able to get out anywhere." So, but I was like, I wasn't listening to my wife ever. So I was like, nope, I'm gonna stay at home and we're gonna be fine. So the snow that day, the snow starts going, and I'm obviously on heart attack call. And my wife is very, very diligent. I mean, she's out there. So as soon as like one snowflake is out, she's out there like on with a shovel and throwing the snowflake off our driveway. And so trying to get everything clean so that I can get out and my car can get out and I can get to the hospital if someone has a heart attack. Well, we do this for a long time. We do this for a few hours and then we go to bed. The next thing I know, we wake up in the morning and we have at least 3 feet of snow. So at this point, my pager goes off and they're saying, okay, you guys, we have a heart attack. And so I go to my wife and I'm like, I can handle this. I have one of those big SUVs, you know, with the 26-inch wheels. And they don't have just reverse, they have like super reverse and super duper reverse, that kind of SUV. So I pull in, I get into my garage, and I open my garage door, and obviously the snow is this big. So I get into my car, and she's looking at me like, okay, this is never gonna happen. And I'm like, sure this is gonna happen. And my kids are like clapping for me and everything. So I get in the car, and I put it in this hyper reverse mode, and my car, you know, it starts going back, and I'm like, okay, all right, this is doing it. And the next thing I know, my car stops. And now half my car is inside the garage, and half my car is outside the garage. So my wife is giving me this kind of look like, I told you so. But I'm like, okay, so I've shoveled everything out. I've shoveled out the back of the tires and so on and so forth. And I keep turning and turning the wheels, and it just doesn't go. So the cool part of this story is that the National Guard had to come get me. And so they came in this big Hummer, and I got to the hospital, and I took care of the heart attack. But the most painful part of this whole thing wasn't the snow, wasn't the car, wasn't anything. It was those famous 4 words. I told you so. Okay? So just remember, never have that, and especially don't do it around your kids. All right, so I'm going to start off here. So let's see here. Okay, so this is a little video that I'm going to start with. So I show you this video because I want you to know that things often don't appear as they seem, okay? So as we get older, heart disease will present in various different ways. And the one thing that I can tell you is you have to listen to your body, okay? There's a lot of people, 50% of people who have heart attacks do not come into the hospital because they don't know what's happening, okay? So as we get older, understand that if you're feeling something that's not right, then come in and seek medical attention. So that's one of the take-home points. Don't be those 50% that don't come in. The thing that I'm going to talk about today is something called aortic stenosis, okay? And I don't know if you guys, I'm going to kind of bring it down to a very basic level, so don't feel intimidated by these terms and things like that. And the other thing that I'm going to talk about is something that is a revolutionary therapy that we have. It's called a transcatheter aortic valve replacement, which basically means it is a minimally invasive way to put in a new heart valve inside the old heart valve. Okay, so it's very basic. So let's talk about this. This is one of my patients. Okay, so this is just like everyone here. This is an 88-year-old female who has a history of hypertension, hyperlipidemia. She has coronary artery disease, had Parkinson's disease. She basically came in with symptoms of shortness of breath. So we don't know what that was. She denied any chest pain, denied any other symptoms. She came to me and I heard a murmur when we listened to her. So what is aortic stenosis? So aortic stenosis, so if you think about the heart is like a muscle in your body, okay? It's just like any muscle. The job of the heart is to pump blood to the rest of the body. So the heart pumps blood, it goes to the brain, it goes to your arms, it goes to your legs, it goes everywhere, okay? In between the pumping chamber of the heart and the rest of the body is a very, very important structure called the aortic valve. And the aortic valve, basically what it does, the heart pumps blood, and the aortic valve opens up like this and allows all the blood flow to go through. It's like a gate, okay? So, and when the heart relaxes, the valve closes so that the blood doesn't go backwards, okay? So that's all the aortic valve is. So the aortic valve is a very important structure because what happens is that over time, as we get older, in about 7 to 10% of the United States population, the aortic valve degenerates over time because it has to keep opening and closing. So in about 7 to 10% of people, which is a lot, you get something called aortic stenosis, which basically means that there is calcium or rock that builds up on that heart valve, and it causes, instead of the heart valve to be opening like this, a normal heart valve opens 4 square centimeters, okay? Aortic stenosis, the valve starts opening less and less and less to the point that it opens less than 1 square centimeter, okay? So what happens is you can see here, this is your aortic valve. This is a normal valve, and this is all that rock that's around that heart valve, okay? Now, what happens with, if you think of a faucet, and if you think of a pipe, okay? If we twist the pipe, what's going to happen to all that water flow that's coming from the faucet? It's gonna back up, right? Well, the same thing is happening here. Here is your gate, all right? And all the blood flow has to go to the rest of the body through this tiny gate. And this gate is normally 4 centimeters. Now, if you put a very tight heart valve, which happens in 10% of people, you're gonna get pressure on this heart, the heart is gonna thicken up, and then the heart does something called failure, okay, congestive heart failure, which basically means that the heart says, I can't push against this tiny hole anymore, I'm getting tired, okay? And the heart gets tired and more tired and more tired to the point that the heart starts losing function. So normally a heart squeeze is about 60% of blood flow, okay? When the heart gets tired, it will go down to like 20%, 30%, and that's when you start backing up fluid into the lungs. So this is called aortic stenosis, and this is the sequelae. Now, how would you know that you have aortic stenosis? So there are 3 basic symptoms of aortic stenosis. 1 is chest pain, okay? 2 is shortness of breath. And 3 is passing out spells, okay? So those 3 are the cardinal symptoms of aortic stenosis. Now here is a valve, for example. So if you can all see this, this is your pumping chamber of the heart. This is the other chamber, and this valve that's all white is the rock that's built up on this valve, and so the valve is not able to open up wide. It's opening up only slightly, which is causing pressure on this heart to pump blood flow. The other way we can tell that you have aortic stenosis is we do a procedure called a heart catheterization, where we go in through the leg up to the heart, and we can also measure how tight this heart valve is. Now, as I said, a normal heart valve measures 4 square centimeters. When the heart valve gets less than 1 square centimeter, that's called severe aortic stenosis, okay? So there's mild aortic stenosis, there's moderate, and there's severe, okay? So that's when we worry, when it gets to severe aortic stenosis. Now you must say, why am I talking about aortic stenosis? Well, once I told you that the prevalence in this country is 10% over the age of 65, okay? That's a significant amount. So if there's 100 people in this room, 10 of you are gonna have aortic stenosis, all right? So that's one thing. So the second thing is that the most important thing I can tell you is that we can normally watch aortic stenosis. We can say, okay, you have severe aortic stenosis, but I'm not gonna replace your heart valve yet. The problem happens is when you start getting symptoms. So if I have asymptomatic aortic stenosis, meaning that I don't have any chest pain, don't have any shortness of breath, don't have any passing out spells, and I have severe aortic stenosis by the criteria, I can just watch those patients because our valves that we're born with are the best kind that we have, okay? When you start getting symptoms, meaning chest pain, shortness of breath, and passing out spells, your death rate, your mortality is very sharp here. In 3 to 5 years, 97% of people will die, okay? So that's the most important thing I can tell you, is that when you have symptoms with severe aortic stenosis, 97% of people who don't get anything done will die, okay? So that's why this is such an important disease to diagnose and to treat. So how do you treat it? So when we initially started out, we did something called balloon aortic valvuloplasty, which basically meant that we went in through the leg, and this is what I do in terms of structural interventional cardiology, is we went through the leg, and then we put a balloon in that valve that's opening and closing, and then we just blew up the balloon inside the valve and saw if it got better, okay? So here's that balloon. Here's the valve structure right here, and we're blowing up that balloon. This is a wire that we have inside the pumping chamber of the heart. We go in with the balloon and open that up. But what we found was that valvuloplasty doesn't work. Just putting a balloon in there doesn't work. Why doesn't it work? Because the valve re-blocks up within 6 months. The valve does it on its own. So balloon valvuloplasty was then only indicated in people who we needed to get to a valve replacement, okay? So for example, I have a patient here. So this patient was actually in Port Charlotte. He's an 85-year-old who has hypertension, hyperlipidemia, had severe aortic stenosis, okay? Valve area, as I told you, was less than 1, his is 0.7. And he had a severe blockage in his front artery of the heart, okay? So I needed to fix his front artery of the heart to get him to fix that heart valve, okay? So here are his films, okay? This is called a coronary angiogram. This is a catheter that I have inside, and this is your, so what are coronary arteries? So the heart muscle, just like any muscle, is supplied by blood vessels that need to keep it functioning normally, okay? There are 3 major blood vessels that run on top of the heart, okay? And those blood vessels are the front artery, the left artery, and the right artery. When you get blockage inside those blood vessels, that is when we have those symptoms of chest pain, angina. That's that cholesterol plaque building up inside those heart arteries. If you have a heart attack, that means that you have 100% blockage in those blood vessels that are supplying the heart muscle, because once you have a blockage, you have less blood flow going to the heart muscle, and that will cause the heart muscle to die. Okay, so that's why we have to keep these arteries open so they can provide adequate blood flow to the heart. That's called the heart. So here is his blood vessel. You can see right here at the tip of this, he has a severe 70% blockage compared to the thick muscle there. So this is blood flow through the artery, okay? This black stuff is blood flow. This is called contrast dye. So we do what's called a heart catheterization, where we go in through the leg or the wrist. We go up to the heart. We take pictures of the heart arteries by engaging this heart artery and taking pictures, and we see the blockage, okay? So this person has a blockage in there. So what did I end up doing is here's your big artery, here's your aorta, which is the big highway system of the heart, and here's your aortic valve. Do you guys see that? Yep, okay. So what I ended up doing was we went in, we put this wire in through the valve, and then we blew up this balloon at the level of the valve. So now the valve has gone from 0.7 to maybe 1.2, but in 6 months it's going to be 0.7 again, okay? So we blow up that balloon. So now this gives me a little bit of time. Now that the area is bigger, it gives me a little bit of time to fix his heart artery because I have a little bit of reserve. Because what is if you're fixing a blockage and something goes wrong, your heart, the response of the heart is to pump harder and pump faster. Okay? And that's how it gets more blood flow to the rest of the body. It pumps harder and pumps faster. So if you have a hole that is fixed and you can't get any more than that hole out of it, then you can have a bad compromise or a bad complication during that procedure. So what I ended up doing was we ended up opening up that hole a little bit temporarily, and then we went in and we ended up fixing this blockage. We did something called a rotablator. Here is a little, it's basically a drilling machine, okay, because he has so much rock inside his heart artery. We did a little drilling machine, went in there, opened up the blockage, and then we put in a stent there. That's a stent going into his blockage. And then here now you can see it's nice, big, and wide in that front artery. So that is a use for the balloon aortic valvuloplasty, okay? All right, so second thing, how else do we treat aortic stenosis? So aortic stenosis, there's no medicine that I can give you that will take all that calcium or rock away, okay? It's a mechanical problem, it's a plumbing problem. You have to replace that valve, okay? So balloon aortic valvuloplasty is trying to open that up, but it doesn't work. The second thing is our gold standard. And all of you know open heart surgery, right? How many people have open heart surgery around here? So the point of that is that we open up the chest and we put in a brand new heart valve. Sounds great, right? But the average population of Port Charlotte and other counties in the United States, we're getting older, right? So it would be great if we could do open heart surgery on everyone, right? But 40 to 50% of people can't get open heart surgery because they're too high risk. So you have a lot of this I diagnosed at, a lot of aortic stenosis I'll diagnose at 85, 86, 90. I've done a 102-year-old patient. So the point is we diagnose these things late, and we diagnose them in the 7th and 8th decades. And the older you are, the higher risk of complications you have for open heart surgery. It's that simple. So we try not to do open heart surgery in people who are 80, upper 80s, and so on and so forth. So the studies basically showed that 50% of people couldn't even get an aortic valve. So now you've done aortic valve replacement on 50% of the people. What happens to the other 50%? What did I tell you? They die in 2 to 3 years. 97% will die. So we don't want that, right? So that's where this new technology came in that I'm talking about. And I started the program here in Port Charlotte for, I was doing this up in New York and Baltimore, and I came down here to be with my family, and so I started this program up, and this is basically what's called transcatheter aortic valve replacement. Okay, so what is transcatheter aortic valve replacement? So this is a minimally invasive procedure that we do. We go in through the groin. So if any of you have had a heart cath or any kind of, we basically put in a large IV in the groin or in the shoulder artery. And basically we do the whole procedure. We replace an entire valve through that IV, okay? And so the nice thing about this is that there's no cuts, there's no wounds. Patients basically come in for the procedure, they get the procedure done, which takes me about half an hour to an hour to do, and then they go home the next day. Wow. As opposed to being in the hospital for 5 days, and then full recovery from surgery is close to 6 to 8 weeks. So you can see that there was a huge push for this, and honestly, 95% of procedures are being done this way at this point. So what is a TAVR valve? So a TAVR valve, there's two types of valves. One is called a balloon expandable valve, which basically means that there's a balloon on it, inside it, and we open that up, and the valve opens. So I have to tell you about nitinol. So nitinol is a special metal, okay? And you guys must have heard of nitinol. The beauty of nitinol is it's a special metal alloy that has memory, okay? So what it does is that, suppose I create a nitinol structure, a valve, okay? What I can do is I can crimp that valve onto something, and then when I expand it again, it will retain the shape that it originally had, okay? So that's the beauty of nitinol. So all these valves and our stents and so on and so forth are made of nitinol, because what you can do is you can create the structure, you can crimp it down so we can advance it into the body, and then when we open it up, it will stay in that shape, okay? So these are the two valves that we have. One is a balloon expandable valve, which basically is on a balloon, and we expand it, and it opens up inside the valve. The other one is, think of like so we compress it down, and then we unsheath it, which basically means we have a tube over it, and as we pull the tube backwards, the valve opens up into the shape that it's supposed to take, okay? So one is a balloon, and one is a self-expanding valve. Okay, as we've gotten further and further along, the tubes that we can deliver these through are smaller and smaller. And there's a number of sites that we can go into that are minimally invasive sites. So now let me just tell you a little bit of the data behind how this actually, so when we have a new technology, any new technology or any new thing, we have to try it out, right? So we have to see if it actually works. So who said that this valve is going to work or not work? This valve came out in 2009, and we didn't have any idea if we implanted this valve into human beings, if it was going to work or not. So what happened was that the first thing we did was, there was a trial called the Partners Trial. And the Partners Trial was the first trial that this was done on. And basically what that did was it took the extreme risk patients, okay, the patients who are going to have 50% mortality or are going to die or can't get surgery, those patients who are going to die in the next 2 to 3 months or 2 to 3 years if they didn't have the valve procedure and they can't get any surgery. So they compared, so they took those patients and then they had one group that didn't get the valve, and then they took the other group that got the valve, okay? So what they showed is that this was called the Partners Trial, and what they showed was there was a 25% decrease in death in the people who got the valve, okay? So that was the first sign that this technology can work, because otherwise we have all those people who aren't able to get anything, they're gonna die. So this valve was beneficial that way. So then they said, okay, let's look at the high-risk patients. So the high-risk patients mean, so there's the way this is divided is that in cardiac surgery we have scores based on like whether you have diabetes and how old you are and whether you have kidney disease and so on and so forth. So it risk stratifies you and says, okay, do you have a less than 4% risk of dying during a surgery? And that's called low risk. Do you have a 4 to 8% risk of dying during surgery? That's called intermediate risk. Do you have a above 8% chance of dying during surgery? And that's called high risk. And then there's the extreme risk, which is above 50%. And so the 50% showed us that it was beneficial. Then we said, okay, now let's take the patients who can have surgery and those that are high risk. So let's implant the valves in one group of those and do surgery in the other group. And what did we see? What we saw was that they were equal. So what that told us was that the valve replacement was equivalent to surgery. So that was a very positive sign. It wasn't worse. There's a lot of devices that come out that say, okay, you're having much more death with this new technology compared to the old standard technology. So this showed that it was equivalent. Then we looked at the intermediate risk patients, like I said, 4 to 8%. And it again showed the same thing. The curves are overlapping on each other. And finally, it came down to the low risk patients. So these are patients who are 65 years old, have no medical problems, but have severe aortic stenosis. So it came down to those patients, and what that showed is, again, the valve was just as good as surgery, okay? So what has ended up happening is that we have data now that says this valve is durable, meaning that it does well over time, and so now we have this demographic here, we have this kind of algorithm here. So in patients who have symptomatic aortic stenosis, meaning if you have severe aortic stenosis and you have symptoms, if you're prohibitive risk, you just get our TAVR valve, okay? If you are high risk, then you get the TAVR valve, because no surgeon wants to operate on a high risk patient, okay? If you are intermediate or low risk, it's patient to patient. And most patients have a choice, they have a preference, they have all that, and most patients want to do the minimally invasive valve as opposed to get cut open. So that is where we are. But intermediate risk and low risk, we are doing either surgery or TAVR. Okay, so here, let's get back to our case. So I'm going to show you how this is done. So this is our 88-year-old who has lots of comorbidities. We said that she had severe aortic stenosis, she has shortness of breath. We have to do a CT scan of her chest to measure the heart valve. So we do a bunch of studies, ultrasounds and CTs. We have to look at how we're going to access, how we're going to go up the leg, if there's any tortuosity, if there's calcium, so on and so forth. So we do all this stuff up front. And then what we do is then we measure the heart valve. So now in this patient, we picked a 20 millimeter heart valve. And so here's our heart valve. Can you guys see this? Yes?
Yeah.
Okay. So here is our catheter that goes up. Here is your aorta. So the aorta is that big highway, and the valve sits right here. So this is your heart valve sitting right here. And this is what's called a pigtail catheter that allows me to inject contrast so I can see where the heart valve is sitting compared to whether it's in the pumping chamber or it's in the aorta, which is the big artery, okay? And the heart valve sits right in between. It sits right between the pumping chamber and the big artery. So that's where the heart valve is situated. So this, I land my heart valve right here, okay? I take a picture. I want to make sure that it's in the appropriate position. And then what we do is we stop the heart, okay? So then we do something called pacing. And what it does is that basically now my heart valve is sitting in the appropriate position, but if I let the heart beat, what's going to happen to the heart valve once I go up on it? It's going to, wobble, exactly. It's going to wobble and it's going to jump out. So I've had people who basically we have one extra heartbeat in people, and literally the heart valve has jumped out into the aorta, and then you have to go fishing and catch it, okay? So that is not fun. So I would not recommend that to anyone. So what we do is we stop the heart. When we stop the heart, then everything is at a standstill. So how do we stop the heart? We pace it. So normally your heartbeat is what, 60, 80, 90 beats a minute? So we put your heart rate at 200 beats a minute, or 180 beats a minute, for a very short 5-second period, okay? And so what we do is we put your heart rate at 200 beats a minute, so you're not pumping blood, and then the heart is at a standstill. When the heart is at a standstill, so what you're going to see, so compared to the last one here, so see how the heart is moving here? That's the heart, okay? So here, what we see, now watch this. See this is when your heart is at a standstill. So there's no movement, all right? And so what we're doing here is we position we took a picture, we know exactly where we are, and this is called the balloon expandable valve, okay? So now we're blowing up the balloon, and the heart valve is blowing up along with it. And then what did I say it was made of? Nitinol, right? It has memory. So this memory, we had made it just like this, and so it stays exactly in the same position that we made it, okay? So we crimped it onto the balloon, we expand the balloon, the heart valve expands with the balloon, and then it stays expanded, okay? So that is how you deliver a heart valve. This is the other way. So this is the heart valve that I told you about, that you unsheath. Basically, you have a tube, you pull the tube back, and the heart valve expands as the tube comes out. So here you can see, Here's our tube. This is a TE probe that we're checking as we're going along. But here's the heart valve. And so this heart valve looks very different than the other one. It's much bigger, okay? So that's the other heart valve. And that's, the nice thing about this one is that a lot of the patients that we're doing this in have a lot of calcium, so there is a risk sometimes in certain patients that we can rupture the aortic root. Just think about a balloon just going up and it doesn't care what you have in there, right? It's just a balloon that's going up to deploy that valve. Well, I've had patients who basically what we end up doing is it causes a little tear in their aorta, and then once that tear is there, then that's it. That's called aortic root rupture, okay? So the nice thing about this one, for example, is that if I see that patient and I specifically say, okay, this person's a high risk for that balloon valve, let me do the other one, and that has less trauma to the aorta, okay? Because it's just expanding on its own, all right? So here is that one. So this patient got this TAVR valve and was doing well. 2 years later, the patient comes back to me and says, okay, I'm having a lot of shortness of breath and I'm not feeling quite right. So as much as I like to say that I'm perfect in everything I do, I'm really not. In terms of we all have complications, we all have, and this is not a complication, but it's just a limitation of our technology. And so the whole issue is that we have to, it's more important to know how to fix things than to just not expect things or bad things are going to happen. So for example, in this patient, so what you see here is that the patient has a heart valve right here, and this flow, this red and blue flow right here, is basically blood going around the heart valve. It's called a paravalvular leak, okay? And what that means is that instead of all the blood flow going through the heart valve, you have a little bit of blood flow going around the heart valve, which causes blood flow to leak backwards, okay? And so this is a common complication.
Das hier ist das wichtigste Gerät des Wissenschafters. Das
My next
ist
video.
Überlebensradar.
Hello? This is the German Coast Guard. What are you thinking about?
My point is, communication is key here between patients and physicians, okay? So if you have a problem, you need to tell your physician, okay? Communication. So there are multiple issues in terms of complications that we experience with these procedures. And so as you can see, the number one, for example, complication, or there's a 5% risk when we deploy these heart valves, there's a risk for stroke. Okay, because we're basically going into, and this is with surgery as well. So surgical risk is the same, but I want to mention it. Surgical risk is the same, and so what because you're having all this calcium and you're deploying a heart valve, there's a risk that some of that cholesterol plaque, calcium can break off and go to the brain, for example. Okay, so as we have progressed, we have devised newer technologies to figure out how to resolve these issues. So this is something called the Sentinel device. Luckily, we've had a great outcome in terms of our stroke rates. I've done over 1,000 of these cases, and our stroke rate is minimal, less than 1%. And so this device, for example, is something called a Sentinel device. And this basically device, what this is that it's a device that goes into your neck artery. So remember that the aorta, which is the highway system of the heart, off the heart, then gives rise to branches that go to your arms, go to your neck on both sides to supply your brain, and then go to your other arm. Okay, those are called the carotids, all right? And the carotid arteries lead directly to the brain, okay? And that's what, if you have plaque or thrombus or anything going to the brain, that's a stroke, all right? So this device, basically what it does, it's like a filter, or it's like a basket that sits in your neck arteries, and protects any kind of debris from going to your brain. So I deliver these oftentimes in patients. So here, for example, this is how I do it. We come down, we go through the wrist, and come up to the neck artery, and then we deliver this. So this is the artery to the brain, and we deploy this, this is the filter basket. Then I flip this around, and then come over to the other neck artery, and then pull this back, and then deliver the other basket through there, up to here, and that protects your brain from having strokes, okay? So that is, that's when, this is all done through the wrist. It's called the sentinel device. Then you do your procedure, all the debris gets caught up, and then all we do is we retrieve this device, we pull it back out, all the debris is in the filter, and then we pull it out and we take it out, okay? So that is called the sentinel, decreases the risk for stroke, all right? The second thing is we can get what I talked about, paravalvular leak, where we get leakage around the valve, and that is basically, the more leakage around the valve you have, the worse it is. Luckily, this is not a huge problem. This is often seen, again, in less than 5% of people. And now we have, the valves have come on with what's called a skirt, which is like a skirt that goes onto the valve and decreases the risk of this paravalvular leak. We can get pacemakers, so in about 5 to 8%. Remember, the heart valve is delivered right where the electrical system of the heart runs, okay? So when you expand this valve into the electrical system of the heart, in about 5 to 8% of people, you can get disruption of that electrical system. So in 5 to 8% of people, you will need a permanent pacemaker. And finally, there's vascular complications. So I want to start finishing up and basically say, okay, so we had this patient, so as I talked about, we had this patient who was having blood flow go around the heart valve, okay? So what do we do about that? Well, we basically got some CT scans, figured out where this blood flow was going around. Then the next thing we did was we brought him back to the cath lab. So now what you can see here is, you see, this is the pumping chamber of the heart. This should not be getting dark or black, okay? So what you're seeing is that as I push contrast, which emulates blood, as I push that, you can see there's a jet of blood flow going around the heart valve into here. You guys see that? Yeah, okay. So that's called paravalvular leak. So what we end up doing is simply, we want to just expand that heart valve bigger, okay? So we take a bigger balloon, so we brought them to the lab, we put the wire, and we took a bigger balloon and expanded that heart valve. So when we expanded this heart valve, all that side blood flow is gone. So we closed that hole off. But now what you see is there's central. You're getting blood. So when we went in through the leaflets, we caused a little damage to the leaflets. Okay? And so that again can happen. These are known complications. So we caused damage to the leaflets. So now we have blood flow going through the center of the heart valve that we don't like. So here again, this blue and red is blood flow going through the center of the heart valve. So now what do we do? So now what we ended up doing was we need to put in a valve inside a valve. Okay? So this is called valve in valve tower. Okay? And so for example, if you already have a bioprosthetic aortic valve replacement, not mechanical, but a bioprosthetic. No one's doing mechanical anymore. But bioprosthetic, so this is how, surgeons don't want to operate on your chest again because it's too dangerous, there's too many adhesions. So this is called valve in valve therapy, which basically means that you have a valve already in place. I can go in and I can put in a brand new heart valve inside your old heart valve and make it work, okay? So that is what this is. So basically what we have to do here, now this is again, you guys remember from my pictures that these are the coronary arteries or the blood flow to the heart muscle. And so these arteries, so what happens is that you have an old heart valve sitting there. And if I were to put in a brand new heart valve inside that old heart valve, the leaflets of the old one can block the arteries. And what happens when you block the arteries? You cause heart attacks. Okay, right? We remember that? So what we ended up doing was we ended up what's called protecting the coronary artery. with what's called a snorkel technique, okay? And what a snorkel technique is, just think about a snorkel when you're underwater. What does a snorkel do? Basically, it gives you air, right? Well, it's the same thing. So what we do is, we can put a stent inside the coronary artery, hang it out into the big artery, the aorta, which gives you all the blood flow. And that acts as a snorkel, so that even if the valve leaflets of the new valve were to close the coronary artery, because you have a stent there, it is allowing blood flow into the heart arteries. Okay, it's called the snorkel technique. So what we did here was I took pictures. I wanted to make sure that we had everything protected. Then here we go in. This is our old heart valve. This is our new heart valve. Okay, so this is the other one that I chose. We went in there, and then this is the one that expands on its own. And so here we're expanding it slowly. And here again we're expanding it to the point now you have a valve inside another valve. Okay? And so that valve is now functioning normally. This valve, this type of valve, actually has the leaflets which are a little higher than the other one. And so the leaflets are able to open up nicely with that. But what am I worried about? So here's my stent. I still have to worry about the heart artery because now I've deployed this valve. The valve is working, but am I having a heart attack? So no. So now we take pictures and we see that our valve and our heart arteries are both open. Okay, so we did not need to do a snorkel. We did not need to put a stent that extends out in the aorta. And so this was actually, we ballooned it. We took some more pictures of it, and here you can see now you have no blood flow going back into the pumping chamber. This heart valve is working well. You have blood flow going into the heart arteries, so all of this is good. Okay? Okay, so with that, the main things that I want, and we're getting short on time, so I'll leave a minute for questions. The main things that I want you guys to understand is what aortic stenosis is. Okay, I hope I have explained that okay. And that it is a life-threatening disease. Okay, there are different modalities of treatment. There's no medical treatment for aortic stenosis. You know the prognosis, and the treatment options include surgery or minimally invasive valve. Okay, and then the minimally invasive valve has really become a revolutionary technique in terms of what we're doing now, because patients are going home the next day. People are now discharging patients the same day. So so again, it has almost replaced surgery in that sense. But again, there are certain things that surgery is important for, or certain patients that surgery is relevant to. But this is definitely a step in an amazing direction. Yeah, so patients, yeah, so that's a good point. So in terms of which patients should, if patients are getting a heart valve replacement, and I see that, interestingly enough, previous CVA doesn't really make a difference because we know CVAs come from so many different things. But that would be a patient that we could use that sentinel device on and to protect them. A lot of times people have severe blockages in the neck artery. They have 50 to 69% blockage or what have you. And so we don't want to put anything in there because that increases the risk for patients. But a lot of centers, for example, are doing this on every patient. Okay, so no doubt they do a sentinel device on every single patient. My experience has been that the data is okay with that. I don't necessarily do it on every patient. I do it on high-risk patients. But majority of patients, like I said, we've done over 500 in Port Charlotte, and I did a number before in Mount Sinai, New York. You know, we pick and choose which patients they are. Oh, I have cards back there and brochures. Yes, please. Yeah, there's cards and brochures if you want.
I was going to ask the same thing. Do you basically I have a heart issue, which I do because of cancer. Do you have have an office?
Yes.
That I come and see you, or do I see another doctor and he recommends you?
No, you can come see me. The address is right there. Just call, we'll make an appointment for you. And I do, like I said, I do general cardiology, interventional, structural, and peripheral. So I do everything. I do carotid stenting. I've trained in everything from head to toe. In terms of that, so you can absolutely come and see us for anything. The majority of my practice is obviously doing in procedures like this and so on and so forth, but I see regular patients.
What hospital do you use?
So, yeah, so I'm the director of the cath lab over at Shore Point, Port Charlotte. So we have a heart tower there, and we do the procedures in the heart tower. We have a special hybrid room, which is a special room that actually has been designed for this and high-level procedures where we have, it's actually a surgical table, so you can actually do surgery in the room, or you can do all the imaging that I showed you here with a C-arm and things like that. So it's specially designed for that.
I have a nice system over there.
Yeah. Go ahead.
Do you do the same procedure for mitral valve?
So mitral valves are interesting. So mitral valve technology has not advanced as much as the aortic valve technology. So if you remember the mitral valve, so I do procedures for mitral valves. So if a mitral valve is severely calcified, then we do something called a balloon mitral valvuloplasty. So as opposed to the aortic mitral valvuloplasty, the balloon mitral valvuloplasty has excellent results, excellent long-term results. We don't see a whole lot of mitral stenosis or that tightening of the mitral valve because it's often associated with rheumatic disease. So you see it in countries like India and so on and so forth. You don't see it in the US because we don't have rheumatic disease in the US. So the mitral valve, so you can do a balloon mitral valvuloplasty. The second thing is that if a mitral valve is very leaky, for example, then we can do something called a mitral clip procedure, which basically we go in through the leg, go over to the other side, and then we put in two clips, or one clip into the mitral valve, and basically oppose the mitral valve so that they're not as leaky. That procedure is basically for people who can't get surgery, because that procedure is actually shown to be less effective than surgery with higher complication rates. And so it is for patients who are prohibitive risk for surgery. So that's the mitral clip procedure. I actually have some patients coming up who have had a previous mitral valve replacement, a bioprosthetic mitral valve replacement, where I'm going to be doing a valve-in-valve. So their mitral valve has either gotten very leaky or it's gotten very tight. And so I can go in and I'll go into their mitral valve and then open up and then put in a brand new heart valve, mitral valve in there. The other thing that we do is that they don't necessarily need to have a old mitral valve replacement. They can also have what's called mitral annular calcification, which basically means there's a chunk of calcium that surrounds the mitral valve. And so we can actually put in new mitral valves in there. Basically the point is that you need something to hang on to with these, because you're not suturing these valves in, just like the aortic valve. What does the aortic valve hang on to? Why does it stay there? It stays there because there is a rock pile of calcium there. So our body keeps it there because of that calcium. So if you had a completely normal mitral valve or a completely normal aortic valve, and I put in a brand new valve inside that, the first thing that valve is going to do is going to fly off and go into the rest of the body. So you need something to stay in there. And so we're coming up with newer technology for mitral valves that we can do valve-in-valves, and there's different things that are coming out in the next few years.
If you go to another cardiologist and you're at the hospital, would they call you in if it was some of these procedures?
Not necessarily. So everyone has their own reason. So what I tell my patients and what is you ask for me. So it's again, the whole point is that it's.
But you could move from one cardiologist.
Of course,
to
yes,
the other.
and that's your choice in terms of doing that. But the way in terms of you see one cardiologist, they may have a preference to send you to Sarasota or to Fort Myers or whatever it is, whatever the preference. Right, it's at Tampa or Miami or what have you. So the nice thing is that when I came here 4 years ago, we weren't doing any of this. And now we are at a stage in Port Charlotte where we're doing all of these very advanced therapies, which is great because we're closing holes in the heart, we're doing Watchman devices for AFib, we're doing TAVR valves for aortic stenosis. I've done a few mitral valves and so on and so forth here. So this is definitely a good sign.
Thank you.
Right.
How do they decide whether or not they're gonna go up your arm or through the groin?
For a heart cath, you can do either. So it's a doctor preference, patient preference. So I can get through your wrist up to your heart. Sometimes what happens is that there's a lot of vessels in your elbow area that are like going round and round. So so sometimes it's more difficult in tiny females, for example. Their arteries are much smaller. So there's different reasons, but like I said, my preference is to go through the groin. But other people are doing 95% through the wrist. But I do the wrist whenever patients ask. It's just a preference.
They started with mine on the arm.
Yeah.
And it wasn't successful, then they turned
Yeah,
around.
because our arteries in the legs are much bigger than the wrist, and so that's why they probably ran into difficulty and then switched to the leg.
So in other words, a physician would probably think, oh, I'll just do this with the arm on any patient, and then some people will run into trouble.
Yes, so just like anything, it's highways to the heart. So we don't know, we can't predict what's up there. And so when we go up there and we're seeing the complication, it's important to recognize that I'm not gonna be able to do this. I mean, you shouldn't be pushing it and perforating an artery, but you should recognize it and then switch your approach, yes. Yes.
If I have a cardiologist, should I assume that he knows and does these procedures?
No, so this is a special training. So we did, I did my interventional cardiology, which is basically stents and heart related things. Then I did a fellowship, then a second-year fellowship in all the vascular systems, so the neck arteries, the legs, the kidneys, all that, and then brain. And then I did a third fellowship where I did only structural heart, which is the heart valve replacements and all the closing holes in the heart and so on and so forth. So not everyone is trained in all of that. A lot of people are just in 1 year and then they come out of training. So I would say that if you need to check the credentials. One is called interventional cardiology, which is the heart. One is called peripheral interventions, which is all the legs and kidneys and so on and so forth. And then one is called structural heart disease, which is all of this.
Are these structural?
Yes, and interventional. Yes. Other questions? Good questions.
Yeah, great job.
Thank you.